So when I first worked with this individual, what was the subjective part of the evaluation? Well, he's a 26-year-old male. He is a recreational powerlifter, and he lifts probably about 3 to 4 times per week. And this is really his first competition, okay? So he's one of those guys that really likes the idea of powerlifting, but never really got around to signing up for a competition. And he did, and this was his first competition. He really took it seriously in terms of training. I think he purchased an online program somewhere. I don't remember exactly where it was from. And it's probably one of the reasons why he got hurt. I'm not trying to hate on people writing programs or anything. But he was an ex-athlete, all right? So he's done a lot of training in the past, and he's currently a strength coach, so he knows a lot about training, but he's not a powerlifter and hasn't done it for years. He had a gradual onset of left-sided hip pain, and it started with sumo deadlifts, let's say about 3 months ago, and it started with a higher volume powerlifting program. So looking at his program, he was doing 5, 6, 7, 8 sets of deadlifts all in one session, and just a lot of total volume throughout the course of the week. Volume and intensity is often a double-edged sword. It can help you get stronger, right? But if you do too much, it can get you hurt as well. It hurt him mostly during sumo deadlifts, but eventually things like squatting started to bother him. So as the pain got worse, other movements started to hurt that initially didn't. Squatting is one of those. Prolonged sitting was another one, especially driving, getting in and out of cars hurt. So sitting, lifting up that leg, going over the edge, trying to get out of the car, that bothered it. And here's the thing. I would consider him not especially irritable, right? But here's the thing for some of those folks. So oftentimes these guys will kind of ignore this pain because it's starting to affect them a little bit with sitting. Doesn't hurt that bad. They can still train, although it's probably a serious issue. This was a smart individual because he came to see me before it became something worse. But what I will say in my experience, a lot of folks will let this go for longer and they end up being in a worse position because of that. So this competition coming up, he's not particularly competitive. This is his first competition. He's not worried about this competition. He wants what's best for his hip. So he has minimal ego, and he's basically willing to say, hey, I don't need to do this competition. I can forgo this, which is great because we don't have run into that problem of trying to push through pain and hoping that things don't get worse, right? It's also very coachable. When I tell him to do something, he listens to me and goes through the program as written, which is phenomenal, right? Makes my job a lot easier. Getting this better is a pretty high priority. He has a career as a strength coach and trainer, and he really values his health, okay? And that's awesome because it's really going to lead to people following their home program and listening to my advice and probably making things run just a little more smoothly. What I will say is this is not always the case. You have some individuals, especially athletic folks, where they feel the pain and their coping strategy is denial, and they just keep on blowing through pain, and eventually gets to the point where they can't train anymore, and then they have to confront this problem. That wasn't him. He was valuing my services, which is phenomenal, and just showing me that he wants to take care of this a little bit sooner than some other folks will let it go. In terms of training age, like I said, he's new to powerlifting, but he has a large athletic background of baseball and then curling. So curling, I guess, is bigger in Canada. And if you know anything about curling, when you are curling, your trail side leg is in kind of full end range extension. And he actually believes that some of his issues may have originated from that at some point in his past, right? With that being said, he has about, let's say, 8 to 10 years worth of strength training under his belt, mostly training for sports. And powerlifting, it's been a little less than about 6 months that he's been training. His goals are basically to figure out the best option moving forward, right? What do I do? Continue training, stop training, rehab, do I need surgery? What's the best way of progressing, right? And then he wants to get back to exercise. And yeah, he'd eventually like to get back to powerlifting, but it's not a huge priority at this point. Okay. So objective examination, what do we find? So when we start doing strength tests around the hip, so hip flexion, adduction, extension, external, internal rotation, nothing is painful, and he was particularly strong in all those areas. I wouldn't say anything was really weak, right? I didn't use a handheld dynamometer, but really nothing stood out from that perspective, right? In terms of range of motion at the hip, he had pain at end range flexion, which is super common in these folks, right? When we get to the end range of hip flexion, we're creating a little bit of impingement. If that area is irritated, maybe it gives you some pain. He was limited with internal rotation, and that worsens with flexion. So if you bring your leg up into hip flexion and then into internal rotation, that would create some slight pain, all right? Which makes sense too, because if you do have, let's say, a small labral tear, big labral tear, cam deformity, you're bringing the cam into contact with the acetabulum. If that's a tear there or it's painful or symptomatic, you can create some symptoms. From a regional interdependence standpoint, how about the other joints above and below? What's going on? He's a stiff guy, right? So he has poor ankle mobility. He had poor shoulder mobility, T-spine mobility, right? And hip mobility. And the reason why this is important is that if you're stiff in a lot of other joints, then you're going to force extra motion to occur at the hip joint. And this extra motion is what gets these folks into problems in the first place, typically, right? So in terms of looking at his technique, I didn't look at his technique then because, he's painful. I don't want to, load these lifts up and kind of provoke his issues. But we did look at a lot of old training videos. And if you look at his sumo deadlift, I think it's important to look at. He had a moderate to wide stance. So you see some folks, when they pull sumo, they have an extremely wide stance with a lot of external rotation. And this is obviously to shorten the range of motion and get in a nice, strong biomechanical position. But that's also quite a bit more stress on the hip. He didn't have that. Right, he was moderately wide, but nothing crazy, right? The other thing is that he had a neutral pelvis when he was lifting. And the reason why this is important is if you're sitting into anterior pelvic tilt and you have a lot of lumbar extension, that will bring the pelvis down into the acetabulum. The ball kind of bumps into the socket a little bit sooner and create more issues. He didn't really have that. But when he did pull, his hip shot kind of up and back a little bit at the initial pull. And what this can do is it can increase hip flexion, which will increase impingement within the hip. So that could be a potential driver of symptoms over the course of time. So the squat was actually pretty solid when we looked over it. He had solid depth. He was going below parallel. He's not going extreme. He kept a neutral pelvis, which is great. And he had a moderate to wide stance with toe out. And when we ended up evaluating his hip flexion, trying to find what the best squat stance would be for him, he's already assuming the position in his hip that gives him the maximum range of motion. So I actually thought that was pretty good. And the same thing occurs in the squat as a deadlift. His hips kind of shoot up and back slightly when he comes out of the hole, which I don't know is a bad thing from a performance perspective, but from a hip pain perspective, it does increase the stress on the hip, right? And it also does flex the hip more. So those two things can increase impingement. He didn't have any weird hip shifts or weight shifts side to side or anything like that. So lastly, so this patient did come in with some imaging, right? And this is not too common for me. Usually I see folks before they get any imaging, but he actually went to his primary care doc, got some imaging, got an x-ray and then an MRI. And yes, he did have a cam deformity, right? So extra bone on the ball portion of the ball and socket joint. And he had a labral tear as well. And he had normal joint space and normal amounts of cartilage, which is a good thing, right? So if you guys are familiar with some of the labral pathology, cam pathology research, these are actually quite common and can be asymptomatic, although the clinical exam does kind of match up with what the MRI is finding, right? From a palpation perspective, he was tender palpation on the rectus femoris and the TFL. I find this a lot. So folks, after they are developing FAI, they will have a lot of tenderness in certain muscles around the hip. Big one is the rec fem as well as the TFL, right? What I will say is that these are constantly misdiagnosed as a hip flexor strain. I think because they're tender in this area, people point to their pain in the front of the hip by the hip flexor. A lot of times it hurts with resisted hip flexion, right? Or flexing the hip in general. So that leads practitioners to believe it's a hip flexor strain. But you'll see in this examination, it probably wasn't, especially with the resisted hip flexion. That didn't hurt in any way. But when we start poking around a little more and do some special tests, we found a positive Faber and a positive Fader, right? On top of that, he was reporting to C signs. So basically, he's pointing to the front of the hip, around to the groin, putting his hand on the hip joint itself, saying that's what hurts. Lastly, his Craig's test was more or less normal. This is a test to see version of the hip joint, which will influence the amount of toe in or toe out when we're squatting. That's a topic for another lecture, right? So with all of these tests together, basically, we kind of ruled in the femoral acetabular impingement with the labral tear. So we basically agree with the other physicians and agree with the imaging. That's probably what this athlete is dealing with. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain-Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym, that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay. So a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a fitness pain-free mini course. Definitely check this out.